Next, we have a live cardiac intervention demonstration, which will be chaired by Dr. J.M. Ravichandran Edwin sir. He is MD, DM, FACC, FESC, FSCAI, Professor and Head of Department of Cardiology, Tirunelveli. We have a Tavi live recorded case by Dr. Sengottuvelu sir. I request Dr. Ravichandran Edwin sir to please come to the stage.
It gives me an immense pleasure to introduce Dr. Sengottuvelu to this conference, GCDC, where Professor Arulraj is nicely doing this GCDC. And Professor Sengottuvelu needs no introduction. As you all know, he is a national and international faculty doing all kinds of interventional procedures and chairing many conferences internationally. Now, we are going to see a procedure, what he has mastered in India, that is Tavi and TAVR. What is Tavi? You should all know about in patients with bicuspid aortic and calcific aortic stenosis, where the patients will be unwilling, or if the patient is elderly individual, if they don't want surgery, the Tavi is the best treatment of choice, and patient can be discharged in third day. And the compared to SAVR, that is surgical aortic valve replacement, the TAVR, the interventionalist already stealing the show among the surgeons, and Dr. Sengottuvelu will now show how the TAVR is done step-by-step approach. Over to Dr. Sengottuvelu.
Hello, good afternoon everyone. Thank you organizers, and thank you Dr. Edwin, and it's a privilege to present this live demonstration. So before I begin, I just want to know how many of you are aware about Tavi. Can you put your hands up if you know what is Tavi? So I will just have a no. Okay, I'm quite good to see that almost about 25-30% no. So I'll just show a few slides and then we'll go to the live transmission. So next slide. So you know that aortic stenosis is one of the major causes of morbidity and mortality in elderly patients. Next slide, please. Okay, sorry. Okay. So we know that now in elderly degenerative aortic stenosis is more common, whereas in young patients we see rheumatic, but now we see a decline in rheumatic, and more we see degenerative aortic stenosis, or patients who have congenital bicuspid aortic valve progressing to aortic stenosis in later in life. We know echocardiography is a gold standard to diagnosis along with clinical symptoms. What is Tavi? Tavi is now an established procedure for severe symptomatic aortic stenosis, and has been shown to consistently superiority. Now the recent trials have even shown some superiority to over surgical aortic valve replacement. Though initially it started for extreme high risk patients who are not suitable for surgery, it moved on to high risk patients, then even intermediate risk patients, now even the low surgical risk patients. That means if you see a 70-year-old man or a 60-year-old man who has got who's suitable for surgical aortic valve replacement, then he also should be considered for Tavi. There are some concerns in using Tavi in young patients, which I will tell you, but generally if the patients are above 70 years, I think Tavi should be the first choice. Even if they have comorbidity, 100% Tavi should be the first choice, because surgery is going to be of higher risk. So Tavi is a percutaneous procedure done through transfemoral approach. If it's not possible, we have many other access like subclavian, axillary, or even transcaval routes. So just one slide about the symptoms. The symptoms of classical signs and symptoms of aortic stenosis are triad of angina, dyspnea on exertion, and syncope. Once these people develop symptoms, then we need to immediately intervene. Till then, if they have severe aortic stenosis, you can follow them up. I have seen them, some of them even for years, just going on with severe aortic stenosis, but once they develop any of these symptoms, then they rapidly deteriorate. The mortality is high. 50% of them don't make it by 1 year. 75% do not make it by 2 years. So it's a very high mortality, worse than a cancer. But if you catch them when they develop symptoms, you are going to change the life course, and the survival is going to improve. So Tavi, we first performed by Professor Alain Cribier in France in 2002, which was a landmark invention, and I was fortunate to briefly work with them in Rouen, France, long back. So Tavi is again decided by a heart team which contains surgeon. So basically a CT scan is done. CT scan is very critical because we get all the information. We know the valve size, we know the approach, where we go from femoral approach, and we can plan the procedure. I always say TAVI is 80% planning, 20% implementation. So we plan a procedure very well using the CT scan, which is the important investigation before we perform a TAVI. So based on several parameters, the anatomy of the valve, anatomy, whether it's a bicuspid or tricuspid valve, what valve to do, how do we plan, which access, femoral or subclavian or even transcarotid, what are the specific complications for that particular patient, and how do we prepare ourselves to prevent it, and what are the devices we need. So that was the planning, and then now we are moving more to simplification, which means minimally access TAVI, where we do very minimal access. I will show you. These are the major risks of TAVI: stroke, bleeding, heart block, kidney injury, or paravalvular leak. So now we are focused to prevent all these complications, and so we now have carotid protection devices. As you can see, these filters. So we can, in selective high-risk patients, we can prevent stroke by using carotid filter devices during TAVI. And the focus, the future of TAVI in younger patients, I was talking about younger patients, after doing so much of TAVI, now we are moving to more refinement in the technique. What we mean by is, you know that natural commissures of the aorta, which is the point, okay. If you look at the natural, can you see the pointer? I think it's too bright to see the pointer. So if you look at the coronary artery origin in the upper part of the image, you have two coronary arteries coming in. And what we call as commissures, can you dim the stage light if possible so I can show the previous slide? So these are known as commissures. So just you don't want to place a new valve commissure over the coronary artery. If you see on the right image, you can see the three valve cusps. One of the cusps is placed exactly at the coronary artery. So if you place it, this is not seen there, no? So if you place the commissures over the coronary arteries, then they're difficult to cannulate the coronary artery in the future. So I will show you. So this is the patient. This is a coronary artery engagement in a native artery, the first image. The B is after the valve. So there are some issues if you have to re-engage the coronaries. So in younger patients, in the future, the coronary access is important to prevent, a patient may come with an acute MI, you have to do a primary angioplasty, you have to do a stent. So it is important to place the valve in a correct position so that the future access to coronary will be possible. So now let's move to the live case, the video. So there are many other things which we are doing. We are also for tailoring the patient to prevent the paravalvular leak and also the valve durability. Now the valve durability is as good as, and in many situations superior to surgery. What happens is the valve or sometimes the degeneration is faster because now the valve what the surgeons put is an annular level. There are now TAVI valves where the valve is put above the native annulus, which means called supraannular valve. And by putting the valve in the supraannular position, we are able to. Can you have the? I'm just talking to waiting for the thing.
And also multiple comorbidities.
Let's go to the live case.
And she was
recently
recorded
for India valves, so I'm just showing the same one.
And she's been having progressive onset of dyspnea, which is worsening over the last 1 year, and it's more since last 1 month. Diagnosed to have severe aortic stenosis a month ago. Its STS score was 4.7. And Euroscore 2 was 1.34. If you look at the blood investigations, what is striking is anemia, hemoglobin of 9.7. Look at ECG, obviously there is no conduction abnormalities and there is no bundle branch block as well. Look at the echo of the valve gradients, so the 78 and 45 mean gradient, and the aortic valve area was 0.6. That's a very trivial AR with a preserved LV function. It's a type 1 bicuspid. And you can see the fusion between the left and the right cusp. Here she had a left dominant system and minimal blocks in the LAD. Coronary calcium score was only 148. So in most of these situations, we don't generally perform a catheter coronary angiogram, and we go with the CT. Unless we have a very high calcium score and interpretation of CT is difficult. The annulus area-derived diameter was 21.9 and the area was 375 millimeter squares.
So the CT scan is very important.
Thing
so
is, we look at the LVOT,
take a lot of measurements with
almost
CT scan.
the same from the annulus as 22. If you look at the right coronary, it's slightly on the lower side, 10.5, and the left coronary is 12.6. But if you look at and the ICD is 25.8. So clearly looking at the Bavard registry, it's very clear that it's a head, whereas on the left side,
We look at the femoral size also.
high. So we want to prefer for puncture well above the bifurcation in case needed later on. We have the option of putting a covered stent and assess the bifurcation point and the point of puncture. So we can clearly see in the CT there is not much of calcium at the site of puncture. Also, we measure the distance from the bifurcation to the puncture site, which will roughly help us when we do ultrasound guided puncture. We'll be able to go 2.7 centimeters above the bifurcation, and it makes it easier to puncture using the ultrasound. To summarize, the 70-year-old lady with severe symptomatic aortic stenosis with multiple comorbid conditions. She has intermediate risk for surgery with STS score above 4, and she has a type 1 bicuspid with a calcified raphe and mild annular calcium. And the calcium is extending to left ventricular outflow tract, and she has a vertical annulus with a horizontal aorta. The right coronary artery is non-dominant and is arising slightly low, but the sinuses are very wide. And based on the Bavard classification, it's a flare type, and we have to base our measurements based on the annulus, and the heart team decided for transfemoral Tavi.
We look at a bicuspid with the left-right fusion. That in itself is a good thing, because when you have got a horizontal aorta, you may have an easier access into the left ventricle, into the aorta.
I think it's a very nice case. Also, I guess there's some differences between your country and ours, that you probably have many more bicuspid cases compared to us. I agree with the sizing, and I think the main point for me was to actually address whether to predilate or not. I guess when you choose my valve, it's not so important because you can take out the valve again. But in this case, I would certainly consider predilating, both because of the horizontal view and also the large annulus. And then I guess it's the only cases where we actually predilate nowadays with the balloon expandable or consider it.
So we want to do this in conscious sedation, and we don't use TEE, no urinary catheter. We plan to use a single transfemoral access.
Patient is fully awake, so we do only
ultrasound guided puncture. We're going to use a new generation Merrill octocore valve. This is a new valve from Merrill Life Sciences. It's going to be launched today, and this valve is unique. Patient will have better hemodynamics, lower pacemaker rates, thinking of commissural alignment, and now we are talking about coronary alignment. So we will talk about it in detail. So finally, we plan to use vascular closure with a hybrid, a mixture of both suture and plug-based device, and we will have the temporary pacemaker removed once after the procedure. That's the plan. This annulus is at 21.9.
So we size the artery based on these measurements on CT?
My octocore, which is really useful to exactly place it when you deploy the valve at the level of the annulus. And also now they have aligners where it helps us to navigate this and draw a line from the midpoint to the coronary alignment, similar fashion, where you can, I'll show you the crimper where the valve is crimped, making sure the posts are placed exactly at that level.
So
where
we're basically aligning based on the anatomy of the coronary arteries.
Once we crimp it like that and we take the valve inside, just come back to the straight line and keep going, and you land in the right position. Coming to our patient, here we have done this is our CT, where you can see that.
So what we are doing is we are using a model to show that effectively we can position the valve not opposite the coronaries, so that the coronary arteries are free for future intervention. So this is how this is a valve demonstration just before the live case, where we used a model where we have shown that by placing the valve using a technique where we can put the coronary arteries and align it away from the coronaries, so that the coronary arteries will be free for future intervention. You can go one step forward. So I am just going little forward because it's too much of detail may not interest you. So I am just going a little bit forward to make it more interesting to you. So we have started the procedure now.
And, generally, we have now been doing this for the last about 50-60 cases, and we have seen that with one ProGlide, in majority, the blood bleeding stops, and in about
So we have punctured the artery using ultrasound, and today ultrasound guided puncture is the safest way to puncture the femoral artery, because we can visualize the calcium if there's any, so we can know where we are puncturing. So the safety is far now better using the ultrasound guided technique, and this is a percutaneous approach, so we don't use a surgeon. This is just done in the cath lab, and then we put a large sheath.
Smaller sheet, so straight away through the proclave.
Next step, and
My next step is an AL2, clearly, with that, and look around. This is a horizontal.
So we are trying to cross the aortic
AL2
valve.
will not necessarily get me the other side, it'll still get me closer to where I want. And the second thing is that I can
this is the aortic valve.
it
So we got through the femoral artery. Now I am trying to cross the wire through the stenotic aortic valve, because this is a very, very narrow aortic valve, heavily calcified with bicuspid valve. We are finding it difficult. You can see the wire now, wire has crossed through into the aortic valve. So from the aorta, we have gone through the femoral artery aorta, and then retrogradely crossed from the aortic valve into the left ventricle. Now wire is now in the left ventricle, you can see that. And then we push the catheter, through which we put a stiff wire.
So now we have seen, now we have to position one of these transcatheter valve commissioner exactly at 2.57 and then crimp it. Whether you can see that, but that's one of the posts, the post, and which has to be placed now, you can introduce into this. And
Right.
After having tried the MyValve, I must say we haven't the results of the
Now using a balloon
randomized study,
dilatation now.
but I think it's a very good valve. I think we should see the implantation now.
okay, inches,
So-
one plate.
what size balloon?
So this is temporary pacemaker where we can stop the heart and then do the balloon dilatation.
Pacing off.
Now we have removed the balloon. This is temporary.
important aspect of this is
High
to
pacing
not,
will reduce the blood pressure,
once we introduce
and then we are able to dilate the aortic valve.
alignment.
Now I am now going to introduce the valve.
If we keep the Merrill logo up, probably keep it in
So this is a valve being
sinus.
taken inside.
And test, small test. Second is to check the pacing. I think pacing is fine. Check. Okay. Okay. And the third one is to see, make sure the connections are tight. When you inflate, make sure it's correct. Now we can ready to cross.
So we are crossing the aortic valve.
You can see that the aligners are, we can focus and show that. You can see the white lines just facing us. You can see these white lines. So clearly now we are well aligned to one of these commissures. The other thing is, if you can look at the valve, it's not very coaxial. The parallax is still there. So ideally
Correct.
we want to achieve
Correct.
both coplanar view as well as the parallax removed in the valve. So maybe I'll go a little bit caudal
Yeah,
and then
you can
check
see the
again.
valve is foreshortened.
Ideally, we need to have coaxiality of both the device as well as the aorta.
But
Right.
this is a situation we face sometimes in the case. So
Picture. There's a lot of talk about RAO caudal view, even in a balloon expandable valve,
yes.
to look at the depth, which we can minimize the depth if you look at the view.
This looks better, to tell you frankly.
Yeah, we removed the parallax as well, the valve, so
Yeah.
it looks better. We'll just take
Yeah.
one more view and maybe we are ready to go.
Yeah, you just take one.
Yeah, looks good. Yeah.
Now you watch. Now we are
Maybe
going to
do a
inflate the
very-
valve. You can see the ECG will be fast pacing. The pressures will drop, and then we will start deploying the valve. This is a crucial 1 minute where we implant the valve. Volume.
With the LVOT calcium. So once if he feels too resistance, and he will probably stop at that. So we are actually having a nominal volume at 23, which is about 10% oversize. So what we will probably do is, if there is any resistance, he will stop it and not give the full volume. Little inside, picture
Yeah.
again, and we will go up.
Yeah, here you go.
Pacing on.
Can we see the fluoro piece?
Yeah, see the ECG is pacing now.
Okay.
Pressures
okay.
drop.
Inject. Okay, go up.
See the blood pressure. See, we are inflating the valve. It's full pacing, no blood pressure.
Pacing off. Let's see. It's
Seems
pacing
to
now.
be good position.
Yeah, pacing.
You can see the
Yeah,
blood pressure
pressures are
coming up.
getting better.
The valve is in good position.
Looks
if
good.
we have a fantastic result in terms of there's no AR. And let's look at the gradient by echo. The echo, now we can see the valve very well, that there is absolutely no paravalvular leak. Mean gradient is 4 millimeters mercury. And, you can see the circularity of the valve, very nicely circular, which means there's good expansion of the valve. Circularity is important to have a good long-term outcome. And now you can also see the coronaries. You can see the bright posts there clearly.
So if you see the pressure curve on this side, so you have, so you can see that the LV pressure and the aortic pressure. So there was a huge gradient in the aortic valve before we did. There was heavy pressure in the left ventricle. There was low pressure in the aorta because aortic valve was very much narrow. Now after the procedure, we are checking the pressure. This is the left ventricular pressure, is aortic pressure curve, where it shows that there is no gradient, which means the pressure between both the left ventricle aorta is now equal, which means there is no gradient. Next slide. Means aortic stenosis is completely relieved. Next. And we're also looking at echo.
The commissures are clearly away from the coronaries. We can see that.
So this is a new feature.
The positioning of the new.
The new commissures are away from the coronary arteries. Exactly. Next. Go.
Opposite, and you can see that all the three commissures are well away from the coronaries. And in this case where we had a lot of cusp asymmetry, this foreshortening was very less and really helped to predict the valve position at the end of deployment.
So Kristen, anything that you would have done differently or in any other way, your modifications of techniques, having done so much of balloon expandable valve over a long period of time?
Actually, I think I would make the same setup, and also I think it was a great result. So we also do conscious sedation, ultrasound puncture, one radial, one femoral, and in this case certainly pre-dilatation. So very nice case.
You can see that it's a very shallow deployment, and it's probably it's good.
And no aortic leak.
We can see that. And by the way, you're not too deep either on the outer curve or the non-curve or towards the non-curve.
Yeah, exactly.
cusp.
We are not too deep, and
when you see you're practically a couple of millimeters.
So
there.
this is
I think you're doing very good.
actually we wanted to exactly place it like this. We wanted to make sure it's very shallow, and so it was perfectly landed where we wanted.
It has. It's a very good deployment. So that is a great result. So you're
now
coming out, and
we are going to take care of the groin. So here,
Good.
So what we want to point out is we always keep a stiff wire. We put the dilator on, and monitor the pressure when we remove the main sheath. And also, it's important to make sure that we take the pigtail up. So see, as I am doing, we're taking the pigtail up to do an iotogram. So, and we are going to see if one proglide is going to seal the bleeding. If not, we will put a 8 French angioseal. Senthil is removing the sheath. Remove it slowly, and we look at the pressure as well during that time. And see, I have now closed the proglide. Yeah, we always give a reverse half the heparin. We don't fully reverse it. Generally, if you put this sheath, we can put an 8 French sheath and see if the bleeding stops. You see, bleeding has stopped. So that's a way to find out if this is going to help. If you can see now, it's almost stopped. We have a mild ooze, which will probably stop with some mild compression, reversal of heparin.
congratulations, Sengo. That was an excellent demonstration, step by step, of meticulous technique in a very difficult horizontal anatomy, bicuspid valve treated with a balloon expandable Merrill octocore. And these are difficult anatomies to treat. There's a concern around balloon expandable valves and bicuspid anatomy, but you demonstrated it with excellent ability, with a perfect result and safety. I think that was a great demonstration, wonderful expertise, and I think I congratulate you and your team for a clear cut.
It was a pleasure. So I'm looking forward also to get experience with this new valve. So, but a very nice case presentation. Thank you.
Thank you very much. With this,
I just want to show you the iotogram where you can see that the femoral arteries are looking very good.
Thank you. Thank you very much.
Thank you.
Bye-bye.
So, this actually was Professor Kirsten from Copenhagen, Denmark. So, this was a live case which we did it in last month for India Valves meeting in Goa. So, the point was it was a challenging anatomy with the bicuspid heavy calcium. So, we are now moving towards simplification of TAVI. As I told you, this space was fully conscious. Just give conscious sedation, patient is awake, and that is one. Second, very minimal lines. We use one radial, only one femoral line. We don't even put a pacemaker. We pace through the LV wire, and no urinary catheter. So basically, it's simplified. The patient gets home and the next day, most of the time, 50% of the patients we discharge them next day. Some of the patients will need a 2 or 3 day hospital stay. So not only that, with also sophistication in terms of managing the coronary arteries for future access. We know the valve durability, so we are also looking at future need for TAV and TAV, means TAVI and another TAVI again, and also the reduction of stroke using the cerebral protection devices. So we have moved very far from how we started, and we are quite ahead now in the transcatheter aortic valve replacement. Thank you for your patient listening.
Please treat Sengottuvelu for having watched a very nice case of TAVR and a nice demonstration. Congratulations. And he has done a wonderful TAVR without any complications like complete heart block or coronary abnormalities, bleeding risk, stroke, or any complications. So wonderful demonstration. Once again, I wish you and congratulations. Any questions in the audience regarding TAVI and TAVR?
No, I know you have been doing a lot. One other thing is when you put it in a younger patients, as they grow, they will need another one. So, have you done a second TAVI in younger patients?
Yes. So, generally, as I told you, the age still we always want only one procedure for a patient. But unfortunately, we are now having a bioprosthetic valve, which means the valve tissue is made from porcine or bovine tissue, which degenerates within 10 to 15 years. Whether it's a surgical valve or a TAVI valve, today we are using only bioprosthetic valve because the risk of anticoagulation with mechanical valves is very high, and nowadays we don't want to give anticoagulation. So bioprosthetic valve is the dictum of the day today, both surgical and TAVI. So these valves eventually degenerate in 10-15 years. So we cannot manage with one procedure. That's why we have to know the approximate age of the patient and the longevity. Suppose the patient is going to, say for example, a 45 or a 50-year-old man comes with a severe aortic stenosis. I would prefer a surgery first, because we can always do a surgery and the valve lasts for 15 years, say about 55 or 60 years, and then we can always put a TAVI again on that patient, then that will take him for another 15 years. Whereas a patient who is 70 years can go straight for a TAVI because it will again take him for about 10 to 15 years. The question is, very often many patients come and ask me in their 55s whether they can do a TAVI, don't want surgery. I strongly advise them against, unless they have extreme comorbid conditions where surgical risk is very high. So sometimes, with a lot of the patients are very keen, we had to do TAVI, and such situations, these patients degenerate the valve early and a second TAVI may be necessary. So there are many challenges with the second TAVI. It's not as easy because the coronaries, mainly because the coronary, already there is a valve inside and the coronary arteries are very close to the aortic valve. And when we have a valve, there is a skirt which can obstruct the coronaries. And you put in a second valve, because of the skirt, there can be a high risk for coronary obstruction. But fortunately, now we have different types of valve, like balloon expandable, which has a very short frame height. We have a large frame height. We are using now 6 types of valves, and we are currently doing about 2-3 valves on trial. So we have a wide variety. When we started TAVI about 7 years ago, there was only 1 valve or 2 valves. Now we have commercially available valves, we have 6 or 7, and in trial we have about 3-4 valves. So with so much of availability, we can choose which is the best, what is the previous valve, what is height of the valve, depending on the CT, anatomy, the location of the coronaries, the width of the sinuses, we can appropriately put and then now we do also 3-dimensional 3D printing, and we know that we can assess if you put a valve, what is going to happen to the coronary. So using all these assessments, we can suitably choose the correct valve and you do a TAVI in TAVI, which is more complex. But today, with the advances in valve technology, it is designed for future TAVI. If the first TAVI is put a short frame height, then putting a second valve is much easier. So we have to be prepared for the future when we particularly use for young patients. But the young patients, many of them come, I strongly tell them, first should be the surgery and then come back for TAVI. So that should be the ideal. Unless they have a very large annulus which can accommodate multiple valves, I would not encourage doing TAVI in patients who are less than 55 or less than 60 years. Above 60 with comorbid, yes, maybe we can consider TAVI, particularly in our setting where our life expectancy is only about 75 or 80 years.
Thank you for that answer. On the other side, suppose they have a TAVI, then they need a surgery in the next stage. I was talking to the cardiothoracic surgeon. I suppose it is very difficult to remove the.
It's a fantastic question. That's why I've been telling that the first procedure is the most important procedure. So that's why if we subject them to surgery first, the second can be TAVI. The reason is, first, the risk of the surgery also will be lower because a younger patient. And second, doing a TAVI after surgery is the best and easy way to do it. But the reverse, if the patient comes and asks TAVI at the age of 45 and he lands up in a TAVI, doing the second surgery is going to be more challenging. Explanting the valve is extremely difficult, particularly if you use a core valve which is very large, it becomes adherent to the aorta and the surgeon will find it extremely difficult. There are reports coming on the surgical explantation of the TAVI valve, but it has got higher risks and injury to the aorta. So the ideal thing would be surgery, TAVI for young patients. So, or not TAVI, surgery, TAVI, which is more higher morbidity and mortality. So that's why we are now talking about lifetime management of aortic stenosis. It's not just doing the TAVI. Earlier we were only thinking of risk of the procedure. Nowadays that has gone away. With all our techniques we are able to manage. Now we are more discussing about how do we plan the future. Next 15 years, next 30 years, how the patient will be. So as you rightly said, these patients should be avoided, and the younger age they should be forced to tell them the importance of going through the surgery as a first option.
Thank you so much.
So the cost also has come down. We have now, as I told you, there are the 3 Indian valves now available. One Indian valve has got a new version. We are doing one more trial with another Indian valve. So because of the availability of Indian valves as well as the valves, so the prices are coming down. But again, it may take a long time for us to get the same cost as surgical valve because of this research and all these patents. We will have to still bear the cost at least for some time. But since we are doing a lot of trials, we don't deny treatment for many patients. So cost is not an issue. We are trying to see how best we can help those patients who are in need for TAVI. We use both. We use self-expanding, we use balloon expandable. Now we have a new valve called Accurate Neo 2 from Boston Scientific. That is a self-expanding valve which is indeed like a balloon expandable valve. So we use all types of valve. Again, the pacemaker rate is also much less with these new valves.
Sir, when you keep the valve in the high pressure zone, when the pressure, will it cause ischemic necrosis to the adjacent structure which is adherent to that? Will it cause necrosis and ischemia to that underlying tissue and go for any perforation like that, long duration?
So, nice question. See, the important step what we do is CT assessment. So, we look for the aorta size, the sinuses size. The sinuses should be sufficient to accommodate the valve. So, the sinuses are large like that, where coronary arteries arise. So, when there is large, when we push the whole valve and put in, we don't have cause any injury. So, that's why it's important we don't want to oversize it. If you oversize the valve, it can cause injury to the aortic valve. If you undersize it, you will get a paravalvular leak. So, it's so important to size it perfectly, and that is how CT really helps. And long term, once we place a valve, injury is not a problem at all.
Wonderful presentation, Sengottuvelu. Thank you so much.
Thank you very much.
I'd like to thank Dr. Ravichandran Edwin sir for chairing the session and Dr. Sengottuvelu sir for the session. Next, we have a session where there's a debate taking place on diabetic with coronary artery disease, chaired by Dr. C. Sridhar, MD Internal Medicine, retired